You know that your IBD is never random. Whether it's Crohn's or colitis, there's always a root cause. But the question we need to ask is, why does your doctor not understand this? What information do they have that they're telling you this is a lifelong autoimmune genetic condition? Well, in today's episode, I want to break all of that apart with you so you can really understand what's actually happening beyond this rhetoric or beyond this story that you've been told, that frankly your doctor's been told and now they're forced to give to you. But this episode's a little bit different. Instead of the lives I do on my Facebook that I share here with you, this is actually a lecture that I did for the Priority Health Academy. I do these a couple of times a year, and it's for a group of doctors who are leaving the Western world and say, you know what, I don't love that my patients are sick. I don't love that they're just taking medications, that their only options are drugs and surgery. I want to learn more. I want to do better and do right by them by finding the root cause, because they know that your body is here to fix itself, and that's why you're sick and inflamed. They want to know what your body's trying to heal you from. And that's what I'm taking you through today. And so in this episode, you're going to learn why what you've been told is so wrong. We're going to back this up with stats, with studies. We're going to walk through the genetic components and things that are involved and why everything you've been told is wrong. I'm going to show you the primary cases, or the primary causes rather, that I see in over 300 cases of bowel disease now reversed. I'm also going to take you through some of the steps we've used and go through a case study. If you remember the episode with Larissa, who was diagnosed back in 2013 with severe colitis, almost had her colon removed. She said no thank you, came off the drugs, and in 16 weeks had a near perfect colonoscopy report. And of course, there's a Q&A with the doctors in the group at the end of this episode. I'm so excited to share it with you now. Contrary to what your doctors told you, Crohn's and colitis are reversible. Now, I've helped hundreds of people reverse their bowel disease, and I'm here to help you do it too, because inflammation always has a root cause. We just have to find it. This is the Reversing Crohn's and Colitis Naturally podcast. Now, I do these live trainings in my Facebook group every single week and put the audios here for you to listen to. If you want to watch the video versions of these episodes, just click the link in the show notes to get access to our Facebook group and YouTube channel. And for weekly updates, information, tips, and tricks, you can sign up for our email list by clicking the link in the show notes below.
Okay, welcome everyone to October 2024, our master class. And we have today a guest speaker, Josh, who many people already know from our previous lectures and also the Q&A. He's kind of a fixture with us, kind of on faculty at the PHA. So I'm going to let Josh Deck kind of introduce himself to some of the folks in the audience or those listening later who don't know him and his expertise, and then we'll get started on our event tonight.
Thank
Josh?
you so much, JP. Appreciate that. Great to be here. If you don't know me, my name's Josh Deck. I'm a holistic nutritionist, ex-paramedic, and I specialize now in the Crohn's colitis space. My job effectively is to help people figure out why they have IBD, because none of it is random ever. And that's what I want to go through with you guys today. I thought I'd take a very chic approach. Instead of Breaking Bad, we are breaking bowel disease today. And the whole idea behind this is that everything we've been told, and I want to encourage you to really entertain this thought that everything you've been told about your Crohn's colitis patients to date is wrong, backwards, misinformed, or lacking a huge piece of information. And that's really what this lecture aims to do today. And so the first thing I want to go over is just quickly what we're going to be talking about as a general overview for today. So number one, I do want to redefine the way we see IBD. So our Crohn's and colitis patients, when we start to look at it, what does it actually mean rather than just making assumptions based on what we've been told? The second one I want to go over is causes and factors, which will be, of course, the things that I see in my practice. We've now helped reverse over 300 different cases of Crohn's and colitis, most of which are fully off the medication now. Many have yet to go. And there's still a fair bit of layers. You know, it's not a simple process, but we will get there. And of course, I'm going to take you even through some case studies. I got a few that we'll bring up, but I do have one in particular. I was able to get colonoscopy reports from a 16-week trial. And we're talking with a patient diagnosed back in 2013 with severe, who was about to have her colon removed. And so we're going to have a chance to go over that. And then, of course, open to Q&A. Now, moving on here, let's look at IBD as it is defined. Medically speaking, it's long-term chronic inflammatory conditions of the tissues in the digestive tract. Now, it's Crohn's disease and ulcerative colitis. Now, we don't typically know why they happen, genetic, idiopathic, autoimmune, environmental. There's a lot of assumptions being made, but IBD, by its definition, is just inflammation of the GI tract in the two umbrellas of Crohn's and colitis. And so, just to break these down, just to give you guys a bit of a refresher, or if you're listening on another platform, Crohn's disease is going to be something that's inflamed mouth to anus, primarily the small intestine. We do see it to be a little bit different than colitis, which is, of course, of the colon primarily. Now, in Crohn's disease, you can get lesions in your mouth, perianal lesions or fissures of some kind, a lot of the small intestines. And instead of going in long strips, it is patches known as payers, patches, and they tend to go pretty deep and they tend to go beyond just the first layer. So rather than likening it to scuffing your knee on the sidewalk walking outside, instead it does really cut deep, and some complications, fistulas, strictures, and of course malnutrition. So the fistulas, as infections, tend to burrow into the tissues. Strictures when we get narrowing, and malnutrition is an absorption issue. And in colitis, instead of patches of the small intestine, it tends to be large chunks and strips in the large intestine. And it tends to be very surface, like that scuffing of the knee. And of course, there are all the common signs and symptoms across Crohn's and colitis, like blood, mucus, pain, changes of appetite, etc. And we are prone, of course, to things like toxic megacolon, which can be highly emergent, and colon cancer and ulcerative colitis. Now, I want to go to the assumption here that we talked about, that it's this autoimmune condition. We know, or we're told, IBD is autoimmune, genetic, idiopathic, or unknown, and possibly environmental. This is per the Crohn's Colitis Foundation, the Mayo Clinic, and all the big entities who say this is what it is. So autoimmunity is simply a condition where one's immune system attacks one's own tissues. So your body is attacking itself. That's the definition of autoimmunity. And we're going to break this apart here coming up. Now, current treatments, of course, for IBD, you can start off with something very simple, corticosteroids. We see a lot of prednisone, budesonide, or mesalamines, like your 5-ASAs. And of course, there are immunosuppressants, biologics. And if these don't work, snip, snip, out comes the organs. And this is a major issue that I have with this kind of as a general whole. And something I want to look at here, I'll get to that one in just a minute. Let's move on to the next slide here. So let's talk about inflammation. Inflammation is kind of a funny thing because, again, if we assume that this condition is autoimmune, if we assume they're genetic, we assume they're idiopathic, then we assume across the board that inflammation has a reason. It's a natural response to injury or infection. In the case of Crohn's colitis, to define it as idiopathic actually breaks the foundational layer of what inflammation is. And so we want to keep in mind, and this is a thread we'll pull throughout this lecture, that the body does not make mistakes. We only get sick for two reasons, ever, across the board. And I cannot find any evidence showing otherwise. It is deficiencies or toxicities. And those deficiencies may be things like nutrients, it may be micros or macros, even water can be a deficiency, but something has to create it. Or a toxicity where the body is reacting. We'll talk about some of those toxicities look like, but as an overview, it can be microbes, it can be metals, it can be pesticides and toxins, and you name it, flu, virus, COVID, it can be anything. So I want to picture this. If you're out going for a walk, you got a patient who comes to you, and they're going for a walk, they stepped on a nail, they come to you and say, "Doc, it's infected, it's inflamed, I got this nail in my foot, I need some help, I don't know what to do." Now, as a doctor, how crazy would it be if you looked at that patient and went, "Oh boy, that nail's pretty bad, but it's just part of your DNA now. It's kind of part of your biology. There's nothing we can do, and here's some numbing cream. Use this to manage the symptoms for the rest of your life, and if it gets really bad, we'll cut your foot off." You'd lose your license immediately. When we look at things like chronic inflammatory conditions like Crohn's or colitis, what do? Well, it's just part of your DNA and your biology. There's nothing we can do about it. It's inflamed for no reason. Here's some medications to manage the symptoms for the rest of your life, and it does not work. Snip, snip, we'll cut the colon out. It's the same ideology across a different lens, and this is where medicine, I believe, gets absolutely crazy and kind of wrong. And so let's talk about these a little bit here. The current approach, genetic, idiopathic, autoimmune, therefore we can't do anything, therefore take the drugs or do surgery. What we have to look at instead, number one, how could it possibly be genetic if 50 to 60% of the global cases reside in North America alone, which is less than 5% of the global population. When 5% has 50%, we don't call it genetic, we call it an epidemic. And this is why we have to start changing a lens on that. Number two, if it's idiopathic, there's no known cause, it kind of just happening. But we can see that cases have risen over 3,000% since the 1950s, when estimates were about 15 and 100,000. To the 1970s was about 45. To the 1990s, it was 150 to 250 per 100,000. To today, where it's 463 people per 100,000 in North America have Crohn's or colitis. This is massive. And we're talking, that's what, 5%? That's an insane amount. On top of this, 70 to 72%, depending on the studies we look at, complain of some kind of regular gut issue, like constipation, diarrhea, cramping, bloating, pain. And we know that 17% of all IBD diagnoses have a previous diagnosis of IBS. Well, if 70% of the whole population complains of symptoms in line with IBS, it makes sense only 17 to 20% have a diagnosis, and then it can progress. So we do have a progressive spectrum to consider. The next one is if it's autoimmune. How can it be autoimmune? A, if we're not actually testing every patient for antibodies, we're making an assumption. And B, I'm going to show you some information coming up here to show you that most cases do not have antibodies. And the ones that do, they are likely not actually attacking their own tissues. I'm working on a new hypothesis for this. I can't find any research, but I would love to hear from you. Anything in your patients, your clinic, or your contacts, we can research some of this because this lines up with the 300 plus cases we've seen so far. And I'm excited to get into that with you here in a moment. So let's talk about this genetics. Genes we know, we've mapped the entire human genome. We know that there is no single gene that causes these diseases. We know there are genes that are correlated to the disease, where you can say, okay, well, if you have this gene, you are more likely to get Crohn's or colitis, but there's no single gene that causes high blood pressure, that causes liver failure, that causes Crohn's or colitis. It doesn't exist. And we're going to go over some of that correlative information here. But remember, correlation does not equal causation. We know this as scientists, as clinicians. So we have to dig deeper. And so I'm going to show you again, it's actually a shockingly low percentage of people who do not have any genetic components associated. And then, of course, we know genes are not operating in and of their own devices. They are strongly influenced by their environment. Certain microbes, toxins, nutrients, stress, infections, all of these things can influence how your genes express for better or for worse. So we also have to stop blaming our genes. So let's look at this next chart here we got put together. Now, you won't be able to find these charts. I punched a bunch of data into AI and told it to create charts for me. So I don't know how to use actual charting software, but these are beautiful. So these are mine. So here's what we're looking at. You can see in green, these are the bars representing ulcerative colitis genetics or the associated links. And in blue is Crohn's disease. And these are your percentage ratios. On the highest end, 25% of ulcerative colitis patients have this HLA gene that's identified. At the highest end of Crohn's, you have your NOD2 and CARD15 genes. So the most we see in the genetics is 20 to 25%, which means 75 to 80% of these patients do not have any genetic correlation whatsoever. How can we continue to call it a genetic disease if the correlation's not even there, not in a strong enough way to make it identifiable or even something we can really dive into to fix? It's not like we can edit it through CRISPR. There's nothing that's going to be done. And on the low end, we got 5% that we're calling this TNF-SF15 gene, for example. 5% correlation. Why do we even bother looking at it? And I know that's kind of a stupid question in a room full of doctors and clinicians, but you get the idea. We're blaming the wrong things. And so the next one here, I do want to look at some of these genes and explore a little bit more in detail, though, so we can understand why. This is a thread we're going to pull on during this talk. So let's look at some of these genes here. You can see these are the associated genes and what they're designed to do. So your PARC7s, your STAT3s, IRGMs, IL-23Rs, NOD2s, these are the genes we have associated or attributed to Crohn's and colitis and said, if you have these, it's a genetic thing, there's nothing we can really do. This is sort of the assumption. However, we have to recognize these genes have functional responsibilities. So they do certain things. And if they're affected by their environment, microbial or otherwise, the genes are going to express negatively. So let's look at how many genes we have in the blue bar. There's 4 of them in the blue bar. These are responsible for microbial interaction and microbial recognition, which means they recognize bacteria and things in the gut and they initiate an immune response. So their job is to look at this and go, wait a minute, that's a problem. Let's deal with that. We'll create an immune response. Well, if your gene is being expressed negatively, the immune response is going to be unhealthy. Therefore, when it identifies a bacteria, it's going to go haywire. And now you have a hyperinflammatory response inflaming your entire GI tract. The maths. Let's look at your IL-23Rs or STAT3s. So these ones here, where you got IL-23R and STAT3 in green, immunomodulation. And so they play a role in regulating the immune responses to ensure that immune system does not overreact. Well, if they are being negatively impacted in their ability to read, interpret, and react, then of course they're going to overreact. Because when your body has a problem, it doesn't downregulate systems, it upregulates systems. It's on high alert. Just as if we were outside, you get stuck in traffic, somebody breaks your back window, you're driving, somebody's chasing you through traffic, you're high alert. You get in the house, what do? You shut the door, you lock it, you close the blinds, you call the police. You're on alert. Amazon guy knocks at the door, you scream. Normally you wouldn't. Neither would your genes. But considering the threat they're under, they're expressing poorly. Looking at the HLA gene, for example. Now, this one here is, again, commonly implicated in things like ulcerative colitis, especially. But this HLA gene, it's responsible for presenting microbial antigens to the immune system. It brings it forward and says, here's the problem. Do you think we should act on it? Again, if it's negatively influenced, of course, we're going to have an elevated immune response. And so the next slide here we put together is a chart. This one is the things that influence the genes, the things we just sort of talked about. So look how much of these genes are influenced by other factors. Now, the reason I put these here, microbial interaction, immune responses, inflammatory responses, environmental factors, cellular stress, diet, and nutrient transport. In the cases of inflammation, all of these things are going to be a problem. And in my clinic, in my practice, I should say, the primary things we see driving IBD, of course, are toxins, microbes we'll get to a bit more in detail, but parasites, like we see a lot of parasites. We see Clostridia, E. coli, Candida. We see certain toxins, heavy metals, poor drainage pathways, which create cellular stress, inflammatory responses, microbial interactions, and of course, our genes are reacting poorly. So the primary drivers I've seen in over 300 cases influence our genes negatively. Of course, the roles that they're responsible for are going to be poor. Of course, the outcomes of our inflammatory responses or immune pathways are going to be poor because the input does not create a healthy output. It really is, in my opinion, that simple. And so I want to show you this chart here to back up my claim. We talked about the distribution. This is for the CDC. Now, there are estimates saying that we have cases anywhere from 6 to 8 million today. It really depends on who you ask. But the CDC, in their own report back in 2019, showed that 3.1 of 4.9 million cases of Crohn's and colitis around the world were in the USA alone. 63% of the cases in less than 5%, about 4.7% of the global population. This is an epidemic. And I asked AI once again to put it in a visual chart representation, and you can see the cluster of IBD that we have around here with the numbers and the stats that we were able to pull. And it's interesting, this is pretty accurate to my own experience. I have a fair bit of outreach from India, a little bit from the Middle East. I do have a lot from the UK, Australia, and New Zealand, but primarily the USA. I bet you 80, 90% of our clientele is USA. The rest would be some in Canada, but UK is a huge resource. And so this is a big problem. So we have to look at the westernization and industrialization of these worlds and how it's relating to the creation of these pockets of bowel disease. So ultimately, consider, are genes really to blame? If you're telling your client or your patient that it's just a genetic issue, without maybe knowing it's a lie, we are lying to our patients because we're blaming something that is more of a bystander effect. The genes are being manipulated by external factors. So it's not just genetic. Things change. Microbes, toxins, inflammation, cellular stress, detoxification, drainage pathways, diet we put in, nutrients, environment, whatever it might be, they change your genetic expression. So the first pillar of genetic, idiopathic, and autoimmune completely dismantled. Can everybody agree with me on that one? Awesome. Okay, beautiful. Love that. So let's talk about the next one then. Autoimmunity, the third leg to the table of IBD. We want to talk about this. The definition of autoimmune is your cells attacking your tissues, but you have to have antibodies for it to be autoimmune. That is the definition of autoimmunity. There is an antigen and then an antibody created, and it attacks. Bing, bang, boom, problem solved. However, if you see a lot of Crohn's colitis patients, when was the last time you tested their antibodies? When was the last time you had somebody come to you for help as a functional practitioner who has an antibody test to say, look at all the antibodies I have? That's our consideration number one. Number two, we have to ask ourselves, autoimmunity by definition is your body's attacking its own tissues. But what if it's not? A lot of the antibodies, I'm going to show you some charts here in a minute what these antibodies look like, but these antibodies not only attack potentially your own tissues, but they're more likely attacking certain proteins or membranes or certain cells within the body. And again, by bystander effect, your tissues are simply caught in the crossfire. So your Crohn's and colitis is inflammation by proximity, not your body attacking itself. And so we're going to talk about that here in a minute. So let's get into this one here a little bit. So these are the antibody charts that we have for Crohn's and colitis, and this is pulled directly from, you can find these on PubMed and all over the place. So the most we see here in red, this is ulcerative colitis. Blue, of course, is your Crohn's disease per the legend. Now, we see a much higher prevalence of antibodies in Crohn's disease. No doubt about that. But looking at this chart, about 70% of all patients who've been tested for antibodies with ulcerative colitis have this P-ANCA antibody. So this is our perinuclear anti-neutrophil antibody. So this means your body is attacking the neutrophils. What's the number one thing that we test in patients when we're looking for the progression or regression of bowel disease? It's going to be calprotectin. Well, calprotectin is simply a byproduct of neutrophil activity. So if you have an abundance of neutrophils coming in to clean up something, neutrophils operate through phagocytosis. So if they're in there cleaning things up, of course, you're going to have elevated calprotectin. It's like having a lot of cars in one parking lot idling. You're going to have a lot more exhaust in the area. Duh. And so why are we looking at calprotectin rather than going deeper? Look at these other ones. ASCA, anti-OMPC, all these antibodies, we're talking 10% or less in ulcerative colitis. Okay, so we have elevated neutrophils in ulcerative colitis. That's a gimme. They're there for a reason, right? And then in Crohn's disease, we do see a lot more antibody activity. Well, let's take a look at these antibodies. We're assuming, again, the definition of autoimmune is that your body has antibodies attacking your own tissues. However, this chart shows you what other things these same antibodies can attack. Many of these are the primary causes of Crohn's and colitis we just talked about. Parasites, mold, fungus, yeast, overgrowth, toxicity. So take a look at this one. P-ANCA, right? The antibody we see 70% of the time in ulcerative colitis. Antibiotics can elevate it. IBD drug therapy. So I believe I'll double check this one. I have a chart specifically somewhere, but mesalamine, azathioprine, Imuran, we see these creating the exact same antibodies. So if your patient comes in and does have antibodies, number one, are they medicated? If they are, that can create the same antibody. Look at Crohn's disease, fungi, bacteria, IBD drug therapy, bacteria in mold, bacteria, fungi, parasites, anti-12, bacteria, antibiotics, IBD drug therapy. All these things that we see as the primary thing your body's trying to react to can create the antibodies. The drugs we use can create the antibodies. So to say it's autoimmune, as if your body randomly began starting attacking your own tissues out of the blue because it was bored, woke up one day and your body was just revolting, it doesn't make any sense. That is a logical fallacy. They have to be going after something. And antibodies are going to be more likely in many cases attacking a foreign pathogen that maybe looks like your own tissues or proteins that you create. And so if we have some correlation here, let's look at this. This is sort of my hypothesis I'm now working on, and I would love some help with this one if you guys want to, maybe get a Nobel Prize with me here. But take a look at this. Your body, it's likely inflamed due to the bystander effect. If your body is attacking something within its own tissues, that would be a problem. given the fact that we've got 300 plus cases we've now reversed. We've seen all these commonalities, bacteria, could be E. coli, we've seen Giardia, different parasites, we've seen E. histo and Blastocystis hominis and D. fragilis. There's 1,400 kinds of parasites that can attack humans out of the million or so that we believe exist on planet Earth. And so, if they're attacking other things or your body's reacting to them, it's a problem. Fungal overgrowth, major driver, right? These are the things. But the antibodies will attack protein specific or the membrane specific to those drivers. Therefore, we must ask, are they attacking your tissues? Look at Pianka. 70% of all ulcerative colitis patients tested in the study had this antibody. So this is the anti-neutrophil antibody. Is it attacking the neutrophils, or because the neutrophils operate through phagocytosis, they eat and consume? Is this antibody going after the neutrophils themselves or going after the protein contained within the neutrophil? This would change the entire ideology of autoimmunity entirely, will change the landscape. If we have this anti-neutrophil antibody, the assumption is that your body's attacking your own neutrophils. But if the neutrophils are there to clean something up, what are they cleaning up? And if the antibodies are there, are they attacking the neutrophils or the protein inside the neutrophils that they're trying to clean up? If this is in fact the case, and I'm telling you guys, I need help trying to prove this theory, but it would entirely change the landscape of how we see autoimmunity, especially in the case of IBD, possibly the landscape of autoimmunity across the world. Now, I did run a search for research like this. It sounds like there's some theories ongoing, but nothing conclusive at this time. So this would be forefront type of stuff. If you can find any information on it, please do contact me and I'll provide as many bodies as we need to get the testing done. But that's my thought currently. So are we making sense so far on the antibodies and how that's another bullshit logical fallacy? Perfect. All right, let's move this one on then. Next one, idiopathic, unknown cause. Well, we talked about cases rising exponentially, 3,000% in the last 75 years. So something has to be causing it. If idiopathic is by definition, there's no known cause, is that there isn't a known cause or we're not recognizing the causes willingly. We're going to talk about some of this as well and what's gone on in the world. But look at the chart we just showed you, the world map. Look at the concentration. European countries, especially Western Europe, so very industrialized, USA, and even some Australia, New Zealand. These are the most westernized cultures in the world. They have some of the highest food share in the world, the highest pesticide use in the world. Look at India. They have something like 8,000 pesticides approved for use across billions of people, relatively small concentration, even just the numbers of IBD. The USA has 18 to 20,000 pesticides approved for use. Glyphosate, known to cause cancer, labeled as a carcinogen. In fact, Bayer, who was bought by Monsanto, actually just paid out recently, I believe it was 11 or 14 billion dollars to settle over 100,000 lawsuits, with 30,000 to 40,000 still pending for glyphosate causing cancer, yet it is still approved for use in the USA and banned in dozens of other countries. So if it's idiopathic, something is driving it. We do have more medication use than ever before. It's actually gone up, calculated for inflation, by 222 times since the 1950s. We have more processed and refined foods than ever before, more sugars than ever before, 101 pounds per year for the average adult in the USA. That is the size of a panda bear, just to give you guys some context, okay? Sugars, seed oils are up exponentially. There's another interesting theory we look at called generational dysbiosis. If you're familiar with the work from, I believe it's Stanford, Dr. Justin Sonnenberg and his wife Erica Sonnenberg, and they talk about this generational dysbiosis that we are going to get to here and sort of talk about in a minute. But these are what I believe are the driving causes. Now, this little chart again we put together to show you the increase in bowel disease over the last 75 years. If we don't know what's causing this is a 45-degree line. If we don't know what's causing this exponential growth, we better figure it out pretty freaking fast. That's my first thought. And so ultimately, I want to pose the thought, is this truly an unknown cause, or are we ignoring the cause? Now, dare I say the conspiracy word, but consider the three biggest industries in the USA make up 18% of the entire GDP, worth $4.7 trillion a year. That's going to be hospital stays in like medical care, health insurance, and pharmaceuticals. Now, you'll notice how many CEOs will bounce around from big food to big ag to big pharma to FDA. They just jump around. Now, will we say it's one big conspiracy to make us all sick? Who knows? But can we certainly say there are special interest groups approving certain toxins and certain pathogens for whatever elusive profit? Probably. Are they doing it intentionally or because they're asked to or because they're lobbied to? Who knows? But the reality is there's something terrible going on that's really causing these problems and it's being ignored by higher up authorities. And this is a big driver of our issues. So let's go through this really quick. Primary causes of IBD. We've seen it increase from 1950 to today by 3,000%. So let's talk about generational dysbiosis. Generational dysbiosis is this inheritance of lesser and lesser microbes over generations. Justin Sonnenberg actually did some work. I'll show you this one here. And he actually did some work through mice and over their grandchildren and great grandchildren by slowly changing their diets, introducing them to pesticides, etc. They found that, say, the great great grandmother, we'll talk about that one. I'll just jump ahead in my slides here a minute. So let's simplify this down to the easiest part. If great grandma has 1,000 microbes, we start introducing some toxins. Then guess what? The next baby down has 800 microbes. This is grandma. The microbes we get in our body are inherited through breastfeeding, through our environment, through birth canal, all these different natural processes we inherit our microbiomes. So then great grandma has 1,000, more chemicals are introduced, grandma gets 800, and then she gives birth to mom who has 600, and then you get 400. You have just inherited dysbiosis. So without even starting, you've already got lower defenses due to industrialization, toxicities, etc. Now remember we talked about the only two ways you can get sick ever is toxicities and deficiencies. And so you have a lower defenses because your microbiome, I mean, 70+% up to 90 of your immune system is made and matured inside of your gut. We know that the galt and the malt, that's your mucus layer and your lymphatic associated lymphoid tissues, rather. So your galt and your malt, your gut associated lymphoid tissues, what I meant to say, they're inside the gut. So your immune system largely comes from here. But if your defenses are down, your genes are overactive, your immune and inflammatory responses are overactive, of course, you're going to have an elevated response because you don't have the microbes to keep these things in check because you have inherited dysbiosis. This is a major concern. And so we start to compound this all together. What does it actually look like? Now, in my practice, I put together a little Venn diagram for you here to show you the primary causes of IBD that I see. Now, this first one here, of course, we talk about toxins, microbial imbalances, which could be argued a toxicity, and our deficiencies. But what leads to autoimmunity is a trigger of some kind. We'll get into stress. We'll talk about the genetics and, of course, leaky gut. These are the causes on the outside rings. This is what drives bowel disease. And on the inside, when we compound these, it can create these autoimmune cycles. But then we have to go back. Is it autoimmune with antibodies? Is it actually genetic? And what lines up? What is the body attacking or going after, and why is it being influenced? Now, I'm going to skim through this next part with you quickly because this is taking a bit longer to go through than I thought, but I want to briefly go over microbiome development with you. So there are four main places we get them. First is going to be in utero, when we're born or when we're being developed. Now, it's previously been understood that the baby's or a fetal gut microbiome is sterile, but there is, of course, this fetal microchimerism where we know 33% of the metabolites in blood are actually byproducts of bacterium. And so what shares with the baby and mom is blood. This is our fetal microchimerism. There's sharing of DNA, sharing of cells, sharing of tissues, and even microbes. Look what happens in pregnancy. Typically, we see a lot of inflammatory markers elevated in pregnancy. We see blood sugar issues in pregnancy because we start to see a decreased insulin sensitivity. And so it's almost like type 2 diabetes. Well, if you're already sick, of course, when you compound type 2 diabetes in pregnancy, it elevates and gets worse. But what this is actually doing is you shunt food away from mom and nutrients that more can get to baby. We have inflammatory processes or leaky gut in mom because that actually can allow this translocation of microbes and other benefits from mom to baby. But we treat pregnancy like a disease because we see inflammation, because we see insulin sensitivity issues. But in a healthy body, they wouldn't be a problem. They're a problem in an already unhealthy body that gets pushed over the edge by these natural occurrences. And so there are a few things in utero that can happen. We know mom's gut microbiome does change. And this is actually producing more beneficial bacteria that the baby first gets through breastfeeding and through the birth canal. So a lot of your bifidose and lactose. So this is a natural process. And then, of course, in birth, we know vaginal birth is best. We know that babies who come out C-section actually have worse outcomes. We talk about failure to thrive. They're more prone to eczemas and psoriasis and diabetes and other conditions. And of course, as we're growing, it's like seeding a meadow, that microbiome develops. Best case scenario, you are born naturally, you eat organic food, you grow up on a farm, pesticide free, you play with the animals, you're outside, you're eating food off the land. That is the best way to seed your microbiome. Let's look back at that colored chart that we saw, looking at Western industrialized countries. We do the opposite of these things. We do C-sections about 30% of the time. Bottle feeding is being pushed often more than breastfeeding. We live in cities. We live indoors. We hyper sanitize everything. And what happened during COVID? We hyper sanitized, shut in, didn't see anybody. We did the opposite of what we need to get our microbes to over or to begin reproducing. And on another note, we also have a lot of junk foods that we start to incur. We talked about 100 pounds per year, the average adult consuming sugar, alcohol. Antibiotic consumption is up 43% from the year 2000. Fast food, on average, we're talking 3 times a week. These are nuclear bombs that we drop on our gut. Medication spent is up to almost 1.2. This is back in 2018. I think we're closer to like 2 trillion now per year. Something else to consider. Here's an interesting chart for you. Pull this from drkate.com. This is the introduction of seed oils, your canola, corn, sunflower, soy, cottonseed, vegetable oils. Now we blame red meat, we blame fats and all these things for our gut health and illness that we have today. Well, in the 1950s, that consumption actually went down. Seed oils went up. Well, let's take a look at this next one. Here's that chart that we talked about, the increase of IBD. We can see the rise from the 1950s. Let's put them side by side, and what do you know? Now, I realize correlation does not equal causation, but we know that nutrition has a huge role to play in the health of our guts. If our guts are unhealthy, so are our bowels. And so here's what I see in my practice as our primary drivers. Stress is a big one. Environmental is a big one. Microbes, candida, clostridia, E. coli, parasites. I've seen children at 9 years old with loads of antibiotic use where they came in with bowel disease when they have no family history because you've destroyed your microbiome. When your microbiome isn't there or healthy, what comes in? Other invaders, other microbes will fill in the space, which leads to or can be contributed to by these deficiencies. So macro and micronutrients, short chain fatty acids. One could argue dietary fiber, but that's actually another conversation for another time. So I do want to take you through a quick case study here. This is Larissa. Larissa is a 43-year-old female, came to see us earlier this year. She was diagnosed with IBD, moderate to severe, Mayo score of 3 or 4, I believe. We'll take a look. Back in 2013, she tried every medication. They even moved her on to Uceris, and things got worse. They said, we can remove your colon. And she actually described it as having squirrels with razor blades running around her insides. And the bleeding was so severe. In fact, her first call with me, she was on the toilet while we were doing the call. It was so uncontrollable and severe. And so I'm going to show you some of her colonoscopy reports here. So this is the first one that we do have. Number 1, non-thrombosed external hemorrhoids, moderate to severe ulcerative colitis and proctosigmoidosis or sigmoiditis. She had IVs that she had started. They gave her all the drugs, gave her Lialda, put her on Uceris. Okay. So she's moderate to severe, and you can see the lesions inside her colonoscopy report. We can also see over here inflammation found in the colon, Mayo score of 3, spontaneous severe bleeding, and ulcerations. Previous examinations, the first one we just looked at was September 2023. This is February. Even with the drug, she's continuing to get worse. Colonic mucosa, active colitis, erosion, cryptitis, crypt distortion, all the things. Just the myriads going on. They wanted to remove it. So this is before starting our protocol. What we did with her, 16 weeks, we had to focus on drainage. Detoxing is collecting the trash. Drainage is moving it out to the curb. We found parasites. Take a look at these ones. Negative for dysplasia, no increase in eosinophils, normal colonic mucosa, large, bowel, ascending, transverse, descending, proximal, normal, normal, normal. She had one spot of a little bit of colitis left and a little bit of remaining hemorrhoid after 16 weeks. Mind you, she's got diagnosed in 2013 and had years prior. Normal stomach, normal examined duodenum. The examined portion of the ileum was normal. Single patch of moderately active Mayo 2 ulcerative colitis. Improved since the last examination and they did biopsy. Let's take a look at her next one. The examined portion of the ileum was normal. Single patch, moderately active, Mayo score 2. And look at her colon. Pink, healthy, and near perfect. One little spot that they had found. And I'll just put a side by side for you guys here. So this is our before and after. The one was drugs, immunosuppressives. It was dealing with the ideology of it being genetic, autoimmune, unmanageable, idiopathic. Let's suppress the immune system rather than asking what is the immune system reacting to, and is it autoimmune at all? Are your tissues is your body attacking your own tissues, or is it attacking an invader? And this is what happens after just 16 weeks. And so coming towards the end of this thing here, I will show you guys a few slides just so you're bracing yourselves of what we actually pulled out of our clients this year in the IBD space. I'd say about 80% of our clients do actively have some kind of parasite activity. Upwards of 100% will have them in there, but probably 80+% have these as drivers. So this one here came out of one of our clients as a nurse, 15 years of IBD, same thing, full of melanomas, tried the Entyvio, tried everything, and 16 weeks, went after mold, went after parasites, they were gone. She had multiple ropeworms. This one here could have been a tapeworm, could be a roundworm, came out of a 15-year-old boy. Second day on a parasite protocol supporting drainage, and these were also from the same nurse. Now these next ones get a little wild. These are what's living inside people's bodies. They hide in the crypts, in folds. They hide in the bile ducts. They hide in the liver, the pancreas. They can hide in the appendix. They're very hard to remove. Parasites can feed off of muscle, lung, liver, lymphatic fluid. You wonder why your patients are chronically anemic, going in for iron infusions constantly. They love hemoglobin and iron. When their levels are low, we have to ask why. And these are things we see coming out of our clients. It's a little bit unnerving, truthfully, but this is what can be. Now, some of this, one could argue this might be mucoid plaque. However, these are very clearly some kind of worm. And so here's what I want to leave you guys with. It is so important in practice to challenge the notion and just accept the standard of care to say it's genetic, autoimmune, idiopathic. That leaves us with the only possible treatment of drugs to suppress the immune system. If you accept the fact that your body makes mistakes, that disease is innate to your biology, like the nail in the foot is just part of your DNA, and all you can do is give numbing cream and cut the foot off, we apply the same thing to bowel disease or any other chronic disease. We cannot accept that diseases are genetic, autoimmune, idiopathic, or part of our DNA. Remember that inflammation is never random. Your body is always reacting to something. It is an innate response to defend you, not attack you. You actually have probably 200 checks and balances of your immune system to decide to attack you, or if something attacks you, to go after it, to balance your inflammation pathways, to check your immune system. There are countless checks and balances. It doesn't make mistakes. And the problem is that the standard of care, you're told to follow a protocol, don't ask questions. There's no critical thinking, there's no innovation, no personal or individualization, which means you're stuck just doing what you're told. And so standard of care, I believe, is a cancer. The next one is medication and surgery, obviously, is not the only answer because they're addressing the tissues that are inflamed, not the thing inflaming them. And everything has a why. Even a GI map. You get a GI map from a patient and it's really messy. You're taking their gut bacteria, it's all over the place. Are we asking why? Is it antibiotic use? Is it environmental? Is it a microbe that entered the system? Is it pesticide exposure, heavy metals, some inflammatory response that created the groundwork for these bacterium to overgrow? Every piece of information has a deeper root of why. So even a GI map doesn't give us enough. Why did it get screwed up? There's always something to look at. And one last closing thing here, I do want to give you guys some information for your patients just to share. Of course, you can always reach me, gutsolution.ca, all singular, gutsolution.ca for Canada. We do have a podcast. I do lectures like this every single week. I started publishing them recently over the last few months. It's free, available everywhere, called Reversing Crohn's and Colitis Naturally. And we actually take the video versions and they are available on YouTube at The Gut Health Solution. That's all the information I got for you guys. Thank you so much for your time and your attention. And I really do hope this makes an impact for you and your patients in your practice.
Great, thank you. That's a wonderful presentation. A lot of options to think about and theories. Is there mutual exclusivity with some of the items you mentioned in your lecture as far as idiopathic and autoimmune? And can this theory be applied to other disorders that have been maybe heralded as autoimmune disorders?
Yeah, great question. I'm just gonna flick a light on here, Dr. Sleevey. As the sun's going down and I'm aging, my eyes are hurting in the dark. Wow, I look much more pale in this light. So to answer the question, I wouldn't say it's exclusive to IBD. I mean, if we consider it, the very principles of things being idiopathic don't make sense because your body only inflames or gets sick as a result of something. Number two, the antibodies in this case, this is a theory I'd love to explore. You guys may have the resources or connections to do so. Look at the P-ANCA antibody. Is it attacking the neutrophils or is it attacking something the neutrophil has phagocytosed or consumed? If we can understand this, the body's not attacking itself, rather a protein or a microbe or an organism or a membrane, it changes the landscape entirely. And in that regard, we can start to say, wait a minute, what about every autoimmune condition? If it applies to one, why not the rest? Look at MS. Is it actually autoimmune, or is there something attacking the nervous system, eroding, say, the myelin sheaths that leads to these conditions like ALS? And there's antibodies attacking those proteins, maybe within the nerve cells. Maybe there's a toxin that embedded itself in nerve tissue. Look at aluminum, mercury, heavy metals. Look at parasites in cancer. Is the cancer tumor a mutation of DNA and genetics? Or is your body actually, assuming it's intelligent, enclosing a parasite or a toxin of some kind to protect you? If we can start to expand this thought and just say, what if? I think it opens the door to reversing every disease under the sun. And we take this one step further and go to hunter-gatherer tribes, which we have been studied by guys like Tim Spector and Justin Sonnenberg, who've gone and actually lived there. They don't know what autoimmune diseases are. They've never heard of PCOS, obesity, arthritis. I think ultimately there's a reason we have elderly rotting in nursing homes, and they have elders contributing and hunting at 80, 90 years old.
Mhm. Yeah. What somebody had asked in the chat about what maybe you can comment on some of the treatment options. Where do you start? Where do you end with treatment interventions?
Ooh, so this one's really tricky. I would be happy at any time if any of you want to come and shadow some of the sessions. I'm not running, excuse me, as many groups right now. My mentor Curtis actually has taken over basically every patient or client that we brought in since January, excuse me, this year, just because I'm doing other stuff. But he'd be happy to have you shadow some sessions. But here's what we have to look at. First things first, we cannot evict the tenants from the building if the doors are locked. And so this is where we go to drainage. Now, we mentioned that detoxing is collecting the trash, drainage is bringing it out to the curb. And so one of the things we often look at, of course, grounding, sunlight. If you're trying to drain the bathtub, turn off the tap. So watch your food, your diet, your stress levels. But things have to escape the body. So our main drainage pathways are going to be your skin, your sinuses, lungs, lymphatic, blood, kidneys, bowels, and of course, your liver and bile ducts. We do a lot of the other stuff. If you're constipated, get the bowels moving. High dose magnesium citrate, magnesium oxide, vitamin C. It's better than these petroleum based like laxatives of some kind, like Miralax. But on the other hand, we have to get things out of the body if they're trapped. And so this is where we really have to look at drainage support. So we really go after the liver and bile. That can look like NAC. That can look like milk thistle. We'll often use TUDCA as well. We're big fans of the Cellcore products. They have KL support, drainage activators. But I do recommend if it's your first time working on drainage to take it slow. You can cause somebody to herx through any kind of biofilm disruption, any kind of drainage, any of it. A great example, Billie Jean. I was a client. She was the one with that ropeworm, the nurse I was telling you about with the melanomas. And she was perfectly fine. After 3 months or something, she was off all of her drugs. Again, diagnosed back in 2015, chronic severe weight gain, chronic fatigue, nerves on end, bleeding in the bowels, and all the medications and immunosuppressives. And just by doing mold and parasite, she was perfectly fine. She's like, I have no symptoms. You never know I have colitis. However, we went in and did some biofilm disruption. Now, biofilms are produced by mycotoxins, by different sort of microbes and parasites, and they'll actually take cholesterol and sort of build an armor around themselves. And we started to break that down. And of course, she flared. Why? Because her immune system is still hyperactive. Her genetic expression, due to a decade and a half of inflammation and nutrient deficiencies, is still all over the map. And the minute we opened up this case and it recognized things, then yes, it popped back off and our immune system flared again. But it was a controlled burn. And so we have to be very careful when we're doing drainage, but that is the first step. Second to that, we want to be able to identify what might be driving this inflammation. And so parasites, we have to go by symptomatology. We're talking maybe 40% accuracy at best for your average parasite test. We had a client came in. She was one of those parasite photos that you had seen. She had 8 parasite tests over 5 years that came back negative. And here we have these 4-foot worms coming out of her because they hide, they bind, they bury themselves. And so when we're going to remove, we have to look at the symptoms. That's a whole other lecture of symptomatology. But if you got patients, for example, who have SIBO, they have libido issues, early hair loss, dry skin, psoriasis, eczema, teeth grinding is a big one, or biting of the nails, they can be parasites because they cause neurological irritation, all kinds of other issues. They mess with the valves, trouble digesting fats. That can be a parasite issue or a liver toxicity issue. And once we can go after the root, we can begin removing it. But drainage throughout, on and off the gas of removing while we're replenishing those nutrients is sort of the overarching concept.
Okay, great. Any other questions? We have like 24 folks in the room, and I know there's got to be some burning questions out there for Josh.
Hi, it's Gail Makis. I just have a anecdotal patient that I know. Was a healthy guy, maybe in his 50s, worked as a mason and laying, limestone and that kind of stuff. Anyway, his doctor was hounding him because his cholesterol was so high, but partly was his donut and milk diet. Anyway, he started the statins, quickly got acute pancreatitis so badly that it needed TPN and had to be totally shut down for ulcerative colitis. And then he recovered from that, thank goodness. And then years later, his doctor, really pushed and pushed and pushed on the statins. He went back on them, and then he got UC. So bad that they ended up, they went through the entire gamut. So, and then did a colectomy with a J pouch. So is there any correlation that you have seen? I mean, I've seen it in nephrology, hypertension with chronic heart disease, a lot of patients with gut issues, and worse with statins. Is there any correlation that you've seen with statin use and any kind of UC or colitis?
Well, this is a great question that might take some testing or retesting. So consider that elevated liver enzymes and cholesterol can be another sign of parasites we want to look at. Those are also big ones. So if his cholesterol is up, is it strictly dietary? Is it another influential factor? When we start looking at what statins do, we know statins, they're just a huge moneymaker and really have very little efficacy. But they actually inhibit an enzyme, right? I believe it's HMG-CoA reductase or something. It actually reduces this enzyme, which is involved in the production of cholesterol in the liver. And so we have to look at, has it caused a reaction? If cholesterol is being used as a parasite biofilm or a shield, and you begin removing the cholesterol, does it expose a parasite that leads to an expression of inflammation in the bowel? That's just my first thought off the top, but it's something I have to dive into more. Does that sort of point in the right direction?
Yes, it does. I've seen a lot of patients with the HMG CoA reductase, but I just see a lot of people getting a lot sicker after they're put on statins, and that could be correlated with your US information and your Australia and Eastern European, it would be interesting to look at how many people that have this colitis are on statins. I mean, is
Oh,
that
it'd be a
causing it?
fascinating study.
Yeah,
Yeah,
that would be unbelievably
yeah.
amazing to find out.
I think, Gail, the best guess I could give you with that bit of information would be that the statins can contribute to biofilm disruption because we know cholesterol is a part of biofilm production. And so if those biofilms are hiding microbes, or consider in the gut, biofilms are like a layer. And if you disrupt biofilms, we let out all these different toxins. You disrupt the cholesterol surrounding the parasite or the microbe or whatever it might be, it's exposed. We now have a reaction. And look at the toxicity of the liver as well. We know 95% of our bile recirculates, right? That enterohepatic recirculation. And if that becomes disrupted, you end up sludging up your bile even more. You end up reabsorbing toxins. You contribute to the toxicities, which contribute to disease. Um, so that's where I'd start to look. That's again just a knee-jerk reaction.
Great. Thank you.
Mm.
So Josh, we had a teenage boy a couple of years ago who had very bad Crohn's disease to the point where he failed so many therapies and the surgeons wanted to take out his colon. His parents like flipped out because they didn't want to see their son with a colostomy bag for the rest of his life. So they reached out to a doctor in Miami who started sort of a functional medicine workup and determined he was positive for many tick-borne pathogens. I think he had 2 or 3 co-infections, and that's where I got involved. So Dr. Dinetz and myself kind of tag team this kid. Well, we treated his Lyme disease. So there you have parasites,
Mhm.
and he may have had babesiosis. So I'd have to go look again. And then he was on low dose naltrexone, which helped tremendously with the symptoms. After his Lyme treatment, he got away from the failure to thrive mode and started gaining weight and participating in sports. The finishing touch was some peptides. Thymosin alpha 1 subcutaneously for 2 months was the icing on the cake. And when he went back to his gastroenterologist for a repeat colonoscopy, they could find not a single lesion. So we actually wrote up as a case study, and we got it published on Sirius. It's out there if you want to look it up. But that was an interesting case of
Please.
a root cause. And in the parasites, not necessarily, we didn't necessarily find any intestinal parasites, but the parasites of the Borrelia species, if you will,
Yeah.
was what seemed to be plaguing him. And
Yeah.
we may be using that term autoimmune a little too loosely, but you're right. I mean, where are the antibodies that you're looking for? Now, like in Hashimoto's and Graves' disease, yeah, you can find antibodies that attack certain kinds of thyroid tissue. Um, and but it's interesting. Maybe we do need to
Mhm.
kind of look at things from a different perspective.
Yeah, and all these things, what I'm producing here are presenting really as a hypothesis. Sidebar, look for elevated eosinophils as well. Patients with EOE, elevated
Mhm.
eosinophils in the blood, or um, eosinophil activation protein in stool, sign of parasites. But
Mhm.
what I'm presenting here, there's two ways to look at it. Years back, I actually got offered a position when I was personal training as a dryland hockey coach. And I'd never played hockey. I played road hockey like 3 times. I'm not much of an athlete despite the cool goatee and man ponytail. But I would have been a great dryland coach because my job is to pick up things that these guys would never do because they're in their pattern. And I think that's part of what makes what we're doing so effective in this space. On the other hand, there's huge deficiencies because there may be certain technical fallibilities or fallacies in my work because I'm not a medical doctor or classically trained. This is all self-taught. And so you know, like in antibodies in Hashimoto's, you can see them attacking the thyroid tissue. So in some of these antibodies, I could be way off base, but I'd venture to guess that some of them need to be questioned more than a broad brush stroke, especially given the stats and the data that we have.
Right. Well, it's funny you mentioned, the credentialing process. So I'm working with some national groups on trying to create a parallel healthcare system educational program that sort of breaks down the barriers of like MD, DC, ND, LAC, all those kind of artificial barriers. We're all healers, And what we're trying to do is develop a curriculum and then eventually a way to check for competency to issue a certificate for people that are exemplary healers. And they don't necessarily have to have a bunch of letters after their name. I've seen some, some of my PAs that are in the room right now and nurse practitioners are stellar. They are better clinicians than some of the doctors that I know, okay, that I'm embarrassed to call doctors, especially now in this environment. We're pushing the goal is to develop a curriculum and a new system of educating young people and actually educating some of the old folks who are wanting better. So keep your ear to the rail on that. It should be launching pretty soon. We're thinking in the Southeast.
Amazing.
Yep. So
Yeah,
maybe
I very
you
much
can,
look forward to that.
maybe Josh, you can be an enrollee and be a graduate, and then we can put some letters behind your name.
That'd be great. My last name has as many letters as my first name. It's not much to show on a piece of paper.
Right. Okay. Well, listen, we're at the top of the hour. It was a great turnout today. I think this was one of the largest turnouts we've had in a long time. And I think just by posting Josh's name on the program, we got such a big turnout. So stay tuned for next month.
Thanks so much for listening to this episode. Now, I want to make an ask for you if I can. If you find that this is really bringing clarity and it's giving you information around your bowel disease that you've never had before, and it's bringing answers to problems that you thought had no solution, I would just ask that you leave us a comment, a like, or a review on the podcast. If you're not following on social media or the YouTube channel, those links are below in the show notes. This show, this information has the power to change the face of the way we treat bowel disease across the world for the rest of time, not only for you, but those who come after you. But it only grows when you like, comment, or share, and send this to someone that you love and care about who you feel can benefit from this. Thank you so much for listening, and I hope we'll see you again on the next episode.